Hi viewers, this is Dr. Mir Jaffar from Valley Fertility Centre. Today I would like to discuss with you a very important, very interesting, although very challenging case with all of you. A patient aged 30 years was referred to us with the complaint of retrograde ejaculation and non-obstructive azoospermia. When this patient walked in and we had a look into this patient, the patient was already treated medically. The first line of treatment was given, which generally they are treated with tricyclic antidepressants like imipramine, 25 mg for 20-25 days, and some antihistamines like Practin and Synarist for about a week. Even after taking this medication, the patient was still showing the signs of retrograde ejaculation. So considering that, we started assessing the patient further. We repeated the semen analysis and it showed the signs of retrograde ejaculation. So next we planned to prepare the patient with sodium bicarbonate. The patient was advised to take the sodium bicarbonate previous night so that next day morning we repeat the semen analysis with whatever the sample comes and also with alkalinized urine and process the urine and then see if there are any motile sperms. After doing that, to our surprise, we saw there were actually no sperms in the urine as well. Of course, it was a retrograde ejaculation, but this was showing a case of azoospermia as well. Then here the game starts. We started looking into both male parameters as well as the female parameters. When we checked the female, that female turned out to be poor ovarian reserve. The AMH was somewhere around 1.05 with 6 follicles on right side and 2 to 3 follicles on the left side. We planned to do the trial TISA. In trial TISA also we saw there were few spermatogonia cells and few mature sperms also. They were all dead. They were checked with the horse and all. They were all dead. And this is what struck with a big disappointment there. Then after that, we started treating the patient. The male patient was treated with HCG 5000 bi-weekly, HMG 150 international unit thrice weekly, and apart from that, the patient was put on letrozole 2.5 mg for 2 months, vitamin D3 and other supplements, vitamin C and antioxidants as well. The plan was to repeat semen analysis after 2 months after this medication. When we did the semen analysis, it was again same thing. The urine was processed, there was no sperm. Then we decided let's go ahead with stimulation with a lot of risk because we were not very sure if we would get some motile sperms. Patient was counseled well and we started the stimulation. Stimulation was normally it was with Gonal F 150 and Ugon HP 150 for 4 days, and then we repeated the scan. Everything was going well. On the day of retrieval, we got 11 oocytes. Followed by that, we did the trial PISA as well as TISA, and finally in the TISA we got few sperms. They were all immotile sperms, and the sample was treated with pentoxifylline to stimulate these sperms for motility. Unfortunately, there were only few sperms. We did not process the sample because they were all immotile sperms. So the challenge was to pick the sperms from the raw sample and inject into the oocytes. Oocytes were kept ready. All 11 turned out to be M2s and beautiful oocytes. Oocyte quality was really good. Even after treatment with the pentoxifylline, we could hardly get 5 twitching sperm, where other embryologists had to witness that it is actually twitching. So we could manage to pick up sperms which were just twitching. 5 oocytes we injected with the twitching sperm. After that, we had challenged. We still had 6 oocytes in hand. The sample was treated with the horse. Even with the horse, we could not see any change in the sperm. Then we call it as a rigor mortis sign. So we literally had to see with the injecting needle, we had to see whether the tail is flexible or not. So we picked up the sperms where the tail was flexible, which are considered vital in this test, and we managed to inject even these 6. Challenge was to inject 11 oocytes. It took us about 4 hours to accomplish ICSI process. And then on the day of fertilization, there was again a disappointment. Unfortunately, there were only 3 oocytes which had fertilized with normal PNs, with 2 PNs, and about 3 oocytes had shown 3 PNs, which is considered abnormal fertilization. And to the biggest disappointment, 5 were unfertilized. So, even after working so hard, and we waited for day 3. On day 3, we managed to get 3 beautiful embryos, 3 8-cell grade A, and 2 were 4-cell with a lot of fragmentation, so we considered that B, and 1 was 6-cell, very poor. So we decided to freeze those 3 8-cell grade A on day 3, and rest other poor embryos we decided let's culture it to the blastocyst and see if we get any blastocyst. But unfortunately, we did not get any blastocyst. There we had a big relief that at least we managed to get 1 transfer with 3 good embryos. And then next was the plan for FET. In the mock ET, it was seen that it was very difficult because there was an acute angle between cervix and the uterus, and it was decided to do under a sedation. So same thing was done, and a little bit of sounding was done. We used the catheter Vallis with stylet, and the process was afterload. When we repeat the test, to our glory and to our happiness, we saw that it was positive with good value. And again, after 14 days when we did the scan, we were all thrilled to see that it was a twin pregnancy. But then unfortunately, one got naturally reduced after some time and the other pregnancy continued, and it led to the delivery of a beautiful female baby and then eventually happy couple out of this. And I'm sure you will follow this kind of strategy in such cases. This is what keeps us going on, to keep us on our toes and thrilled in this field when we crack such procedures which VFC is known for. So we would certainly discuss with you. There are a lot of difficult cases which VFC has cracked, and one by one we will discuss with you to impart the knowledge with everyone. Thank you.